The breast. Comparative and surgical anatomy. The protuberant part of the human breast is generally described as overlying the second to the sixth ribs and extending from the lateral border of the sternum to the anterior axillary line. Actually, a thin layer of mammary tissue extends considerably further, from the clavicle above to the seventh or eighth ribs below, and from the midline to the edge of the latissimus dorsi posteriorly. This fact is important when performing a mastectomy, the aim of which is to remove the whole breast. The anatomy of the breast is illustrated in Figure 53.1. The axillary tail of the breast is of surgical importance. In some normal subjects it is palpable and, in a few, it can be seen premenstrually or during lactation. A well-developed axillary tail is sometimes mistaken for a mass of enlarged lymph nodes or a lipoma. The lobule is the basic structural unit of the mammary gland. The number and size of the lobules vary enormously. They are most numerous in young women, from 10 to over 100 lobules empty via ductules into a lactiferous duct, of which there are 15-20. Each lactiferous duct is lined with a spiral arrangement of contractile myoepithelial cells and is provided with a terminal ampulla, a reservoir for milk or abnormal discharges. The ligaments of Cooper are hollow conical projections of fibrous tissue filled with breast tissue. The apices of the cones are attached firmly to the superficial fascia and thereby to the skin overlying the breast. These ligaments account for the dimpling of the skin overlying a carcinoma. The areola contains involuntary muscle arranged in concentric rings as well as radially in the subcutaneous tissue. The areolar epithelium contains numerous sweat glands and sebaceous glands, the latter of which enlarge during pregnancy and serve to lubricate the nipple during lactation. Montgomery's tubercles. The nipple is covered by thick skin with corrugations. Near its apex lie the orifices of the lactiferous ducts. The nipple contains smooth muscle fibers arranged concentrically and longitudinally. Thus, it is an erectile structure, which points outwards. The lymphatics of the breast drain predominantly into the axillary and internal mammary lymph nodes. The axillary nodes receive approximately 85% of the drainage and are arranged in the following groups: lateral, along the axillary vein; anterior, along the lateral thoracic vessels; posterior, along the subscapular vessels; central, embedded in fat in the center of the axilla; interpectoral, a few nodes lying between the pectoralis major and minor muscles; apical, which lie above the level of the pectoralis minor tendon in continuity with the lateral nodes and which receive the efferents of all the other groups. The apical nodes are also in continuity with the supraclavicular nodes and drain into the subclavian lymph trunk, which enters the great veins directly or via the thoracic duct or jugular trunk. The sentinel node is defined as the first lymph node draining the tumor-bearing area of the breast. The importance of the sentinel node is described later. The internal mammary nodes are fewer in number. They lie along the internal mammary vessels deep to the plane of the costal cartilages, drain the posterior third of the breast and are not routinely dissected, although they were at one time biopsied for staging. Investigation of breast symptoms. Although an accurate history and clinical examination are important methods of detecting breast disease, there are a number of investigations that can assist in the diagnosis. Examination precedes palpation and requires careful observation of the patient both with the arms at rest and also elevated to lift the breast. Small lesions may betray their presence by dimpling or minor distortions when the patient moves. Mammography. Soft tissue radiographs are taken by placing the breast in direct contact with ultrasensitive film and exposing it to low voltage, high amperage X-rays. Figure 53.2. The dose of radiation is approximately 0.1 cGN. Therefore, mammography is a very safe investigation. The sensitivity of this investigation increases with age as the breast becomes less dense. In total, 5% of breast cancers are missed by population-based mammographic screening programs. Even in retrospect, such carcinomas are not apparent. Thus, a normal mammogram does not exclude the presence of carcinoma. Digital mammography is being introduced, which allows manipulation of the images and computer-aided diagnosis. Tomomammography is also being assessed as a more sensitive diagnostic modality. Ultrasound is particularly useful in young women with dense breasts in whom mammograms are difficult to interpret, and in distinguishing cysts from solid lesions. Figures 53.3 and 53.4. It can also be used to localize impalpable areas of breast pathology. It is not useful as a screening tool and remains operator dependent. Increasingly, ultrasound of the axilla is performed when a cancer is diagnosed, with guided percutaneous biopsy of any suspicious glands. Magnetic resonance imaging. MRI. Figure 53.5. of the breast is useful in a number of settings. To distinguish scar from recurrence in women who have had previous breast conservation therapy for cancer, although it is less accurate within 9 months of radiotherapy because of abnormal enhancement. To assess multifocality and multicentricity in lobular cancer and to assess the extent of high-grade ductal carcinoma in situ, DCIS, it is less useful in low-grade DCIS. It is the best imaging modality for the breasts of women with implants, as a screening tool in high-risk women, because of family history. Although biopsies can be performed with MRI guidance, this is complicated by the configuration of the imaging system. With improved ultrasound equipment, an MRI-detected lesion can often be found on a second-look ultrasound and biopsied using this modality. Needle biopsy cytology histology can be obtained under local anesthesia using a springlet-aided core needle biopsy device. Figure 53.6. Cytology is obtained using a 21G or 23G needle and 10 ml syringe with multiple passes through the lump with negative pressure in the syringe. The aspirate is then smeared onto a slide, which is air-dried or fixed. Figure 53.7. Fine needle aspiration cytology, FNAC, is the least invasive technique of obtaining a cellular diagnosis and is rapid and very accurate if both operator and cytologist are experienced. However, false negatives do occur, mainly through sampling error, and invasive cancer cannot be distinguished from in situ disease. A histological specimen taken by core biopsy allows a definitive preoperative diagnosis, differentiates between DCIS and invasive disease and also allows the tumor to be stained for receptor status. This is important before commencing neoadjuvant therapy. Large needle biopsy with vacuum systems. The sampling error decreases as the biopsy volume increases, and using 8G or 11G needles allows more extensive biopsies to be taken. This is useful in the management of microcalcifications or in the complete excision of benign lesions such as fibroadenomas. Triple assessment in any patient who presents with a breast lump or other symptoms suspicious of carcinoma. The diagnosis should be made by a combination of clinical assessment, radiological imaging and a tissue sample taken for either cytological or histological analysis. Figure 53.8. The so-called triple assessment, the positive predictive value, PPV, of this combination should exceed 99.9%. The nipple absence of the nipple is rare and is usually associated with aphasia, congenital absence of the breast. Supernumerary nipples are not uncommon and occur along a line extending from the anterior fold of the axilla to the fold of the groin. Figure 53.9. This constitutes the milk line of lower mammals. Rarely, there is duplication of the nipple on a normal areola. Nipple retraction. This may occur at puberty or later in life. Retraction occurring at puberty, also known as simple nipple inversion, is of a known etiology, benign horizontal inversion. In about 25% of cases it is bilateral. It may cause problems with breastfeeding and infection can occur because of retention of secretions, especially during lactation. Recent retraction of the nipple may be of considerable pathological significance. A slit-like retraction of the nipple may be caused by ductictasia and chronic periductal mastitis. Figure 53.10. But circumferential retraction, with or without an underlying lump, may well indicate an underlying carcinoma. Figure 53.10b. Treatment is usually unnecessary and the condition may spontaneously resolve during pregnancy or lactation. Simple cosmetic surgery can produce inadequate correction but has the drawback of dividing the underlying ducts. Mechanical suction devices have been used to evert the nipple, with some effect. Cracked nipple. This may occur during lactation and be the forerunner of acute infective mastitis. If the nipple becomes cracked during lactation, it should be rested for 24 to 48 hours and the breast should be emptied with a breast pump. Feeding should be resumed as soon as possible. Papilloma of the nipple. Papilloma of the nipple has the same features as any cutaneous papilloma and should be excised with a tiny disc of skin. Alternatively, the base may be tied with a ligature and the papilloma will spontaneously fall off. Retention cyst of a gland of Montgomery. These glands, situated in the areola, secrete sebum and if they become blocked a sebaceous cyst forms. Eczema. Eczema of the nipples is a rare condition and is often bilateral. It is usually associated with eczema elsewhere on the body. It is treated with 0.5% hydrocortisone, not a stronger steroid preparation. Paget's disease. Paget's disease of the nipple must be distinguished from eczema. The former is caused by malignant cells in the subdermal layer and is usually associated with a carcinoma within the breast. Eczema tends to occur in younger people who have signs of eczema elsewhere. Look at the antecubital fossa. Discharges from the nipple. Discharge can occur from one or more lactiferous ducts. Management depends on the presence of a lump, which should always be given priority in diagnosis and treatment, and the presence of blood in the discharge or discharge from a single duct. Mammography is rarely useful except to exclude an underlying impalpable mass. Cytology may reveal malignant cells, but a negative result does not exclude a carcinoma or in situ disease. A clear, serous discharge may be physiological in a parous woman or may be associated with a duct papilloma or mammary dysplasia. Multiduct, multicolored discharge is physiological and the patient may be reassured. A blood-stained discharge may be caused by duct ectasia, a duct papilloma or carcinoma. A duct papilloma is usually single and situated in one of the larger lactiferous ducts. It is sometimes associated with a cystic swelling beneath the areola. A black or green discharge is usually the result of duct ectasia and its complications. Treatment must firstly be to exclude a carcinoma by occult blood test and cytology. Simple reassurance may then be sufficient, but if the discharge is proving intolerable, an operation to remove the affected duct or ducts can be performed. Microdiscectomy. It is important not to express the blood before the operation, as it may then be difficult to identify the duct in theater. A lacrimal probe or length of stiff nylon suture is inserted into the duct from which the discharge is emerging. A tennis racket incision can be made to encompass the entire duct, or a periareolar incision used and the nipple flap dissected to reach the duct. The duct is then excised. A papilloma is nearly always situated within 4-5 centimeters of the nipple orifice. Ductoscopy. Inspection of the internal structure of the duct system, using microendoscopes, is technically feasible but generally disappointing. The affected duct may not be visualized and biopsy systems are currently rudimentary. Cone excision of the major ducts. After Hadfield, subareolar resection, when the duct of origin of nipple bleeding is uncertain or when there is bleeding or discharge from multiple ducts, the entire major duct system can be excised for histological examination without sacrifice of the breast form. A periareolar incision is made and a cone of tissue is removed with its apex just deep to the surface of the nipple and its base on the pectoral fascia. The resulting defect may be obliterated by a series of purse string sutures. Although a temporary suction drain will reduce the chance of long-term deformity, it is vital to warn the patient that she will be unable to breastfeed after this and may experience altered nipple sensation. Benign breast disease. This is the most common cause of breast problems. Up to 30% of women will suffer from a benign breast disorder requiring treatment at some time in their lives. The most common symptoms are pain, lumpiness or a lump. The aim of treatment is to exclude cancer and, once this has been done, to treat any remaining symptoms. Congenital abnormalities. Amasia. Congenital absence of the breast may occur on one, figure 53.11, or both sides. It is sometimes associated with absence of the sternal portion of the pectoralis major. Poland syndrome. It is more common in males. Polymasia. Accessory breasts, figure 53.12, have been recorded in the axilla, the most frequent site, groin, buttock and thigh. They have been known to function during lactation. Mastitis of infants. Mastitis of infants is at least as common in boys as in girls. On the third or fourth day of life, if the breast of an infant is pressed lightly, a drop of colorless fluid can be expressed. A few days later, there is often a slight milky secretion, which disappears during the third week. This is popularly known as witch's milk and is seen only in full-term infants. It is caused by stimulation of the fetal breast by prolactin in response to the drop in maternal estrogens and is essentially physiological. True mastitis is uncommon and is predominantly caused by Staphylococcus aureus. Diffuse hypertrophy. Diffuse hypertrophy of the breasts occurs sporadically in otherwise healthy girls at puberty. Benign virginal hypertrophy and, much less often, during the first pregnancy. The condition is rarely unilateral. This tremendous overgrowth is apparently caused by an alteration in the normal sensitivity of the breast to oestrogenic hormones, and some success in treating it with antiestrogens has been reported. Treatment is otherwise by reduction. Mammoplasty. Injuries of the breast. Hematoma. Hematoma, particularly a resolving hematoma, gives rise to a lump, which, in the absence of overlying bruising, is difficult to diagnose correctly unless it is biopsied. Traumatic fat necrosis. Traumatic fat necrosis may be acute or chronic and usually occurs in stout, middle-aged women, following a blow, or even indirect violence, e.g. contraction of the pectoralis major. A lump, often painless, appears. This may mimic a carcinoma, even displaying skin tethering and nipple retraction, and biopsy is required for diagnosis. A history of trauma is not diagnostic, as this may merely have drawn the patient's attention to a pre-existing lump. A seatbelt may transect or avulse the breast with a sudden deceleration injury, as in a road traffic accident. Acute and subacute inflammations of the breast. Bacterial mastitis. Bacterial mastitis is the most common variety of mastitis and is associated with lactation in the majority of cases. Etiology. Lactational mastitis is seen far less frequently than in former years. Most are caused by S. aureus and, if hospital-acquired, are likely to be penicillin-resistant. The intermediary is usually the infant. After the second day of life, 50% of infants harbor staphylococci in the nasopharynx. Although ascending infection from a sore and cracked nipple may initiate the mastitis, in many cases the lactiferous ducts will first become blocked by epithelial debris, leading to stasis. This theory is supported by the relatively high incidence of mastitis in women with a retracted nipple. Once within the ampulla of the duct, staphylococci cause clotting of milk, and, within this clot, organisms multiply. Clinical features: the affected breast, or more usually a segment of it, presents the classical signs of acute inflammation. Early on this is a generalized cellulitis, but later an abscess will form. Treatment: during the cellulitic stage, the patient should be treated with an appropriate antibiotic, such as flucloxacillin or coamoxiclav. Feeding from the affected side may continue if the patient can manage. Support of the breast. Local heat and analgesia will help to relieve pain. If an antibiotic is used in the presence of undrained pus, an antibioma may form. This is a large, sterile, bronchioedematous swelling that takes many weeks to resolve. It used to be recommended that the breast should be incised and drained if the infection did not resolve within 48 hours, or if after being emptied of milk there was an area of tense induration or other evidence of an underlying abscess. This advice has been replaced with the recommendation that repeated aspirations under antibiotic cover, if necessary using ultrasound for localization, be performed. This often allows resolution without the need for an incision and will also allow the patient to continue breastfeeding. The presence of pus can be confirmed with needle aspiration, and the pus should be sent for bacteriological culture. In contrast to the majority of localized infections, fluctuation is a late sign. Usually, the area of induration is sector-shaped and, in early cases, about 1/4 of the breast is involved. Figure 53.13. In many late cases the area is more extensive. Figure 53.14. When in doubt, an ultrasound scan may clearly define an area suitable for drainage. Operative drainage of a breast abscess. This is less commonly needed, as prompt commencement of antibiotics and repeated aspiration is usually successful. Incision of the lactational abscess is necessary if there is marked skin thinning and can usually be performed under local anesthesia if an analgesic cream such as Emla lidocaine is applied 30 minutes before surgery. The usual incision is sited in a radial direction over the affected segment. Although if a circumareolar incision will allow adequate access to the affected area, this is preferred because it gives a better cosmetic result. The incision passes through the skin and the superficial fascia. A long artery forceps is then inserted into the abscess cavity. Every part of the abscess is palpated against the point of the artery forceps and its jaws are opened. All oculi that can be felt are entered. Finally, the artery forceps having been withdrawn, a finger is introduced and any remaining septa are disrupted. The wound may then be lightly packed with ribbon gauze or a drain inserted to allow dependent drainage. Chronic intramammary abscess. A chronic intramammary abscess, which may follow inadequate drainage or injudicious antibiotic treatment, is often a very difficult condition to diagnose. When encapsulated within a thick wall of fibrous tissue, the condition cannot be distinguished from a carcinoma without the histological evidence from a biopsy. Tuberculosis of the breast. Tuberculosis of the breast, which is comparatively rare, is usually associated with active pulmonary tuberculosis or tuberculous cervical adenitis. Tuberculosis of the breast occurs more often in Paris women and usually presents with multiple chronic abscesses and sinuses and a typical bluish, attenuated appearance of the surrounding skin. The diagnosis rests on bacteriological and histological examination. Treatment is with anti-tuberculous chemotherapy. Healing is usual, although often delayed, and mastectomy should be restricted to patients with persistent residual infection. Actinomycosis. Actinomycosis of the breast is rarer still. The lesions present the essential characteristics of facio-cervical actinomycosis. Mondor's disease. Mondor's disease is thrombophlebitis of the superficial veins of the breast and anterior chest wall, although it may also occur in the arm. In the absence of injury or infection, the cause of thrombophlebitis, like that of spontaneous thrombophlebitis in other sites, is obscure. The pathognomonic feature is a thrombosed subcutaneous cord, usually attached to the skin. When the skin over the breast is stretched by raising the arm, a narrow, shallow, subcutaneous groove alongside the cord becomes apparent. Figure 53.15. The differential diagnosis is lymphatic permeation from an occult carcinoma of the breast. The only treatment required is to restrict arm movements. The condition usually subsides within a few months without recurrence. Complications are deformity. There are case reports of Mondor's disease being associated with subsequent development of malignancy, although coincidental malignancy is more likely. Ductictasia periductal mastitis pathology. This is a dilatation of the breast ducts, which is often associated with periductal inflammation. The pathogenesis is obscure and almost certainly not uniform in all cases, although the disease is much more common in smokers. The classical description of the pathogenesis of ductictasia asserts that the first stage in the disorder is a dilatation in one or more of the larger lactiferous ducts, which fill with a stagnant brown or green secretion. This may discharge these effluents and set up an irritant reaction in surrounding tissue, leading to periductal mastitis or even abscess and fistula formation. Figures 53.16 and 53.17. In some cases, a chronic indurated mass forms beneath the areola, which mimics a carcinoma. Fibrosis eventually develops, which may cause slit-like nipple retraction. An alternative theory suggests that periductal inflammation is the primary condition and, indeed, anaerobic bacterial infection is found in some cases. A marked association between recurrent periductal inflammation and smoking has been demonstrated. This was thought by some to indicate that arteriopathy is a contributing factor in its etiology, although others believe that smoking increases the virulence of the commensal bacteria. It is certainly clear that cessation of smoking increases the chance of a long-term cure. Clinical features: nipple discharge, of any color, a subareolar mass, abscess, mammary duct fistula and/or nipple retraction are the most common symptoms. Treatment: in the case of a mass or nipple retraction, a carcinoma must be excluded by obtaining a mammogram and negative cytology or histology. If any suspicion remains, the mass should be excised. Antibiotic therapy may be tried, the most appropriate agents being coamoxiclav or flucloxacillin and metronidazole. However, surgery is often the only option likely to bring about cure of this notoriously difficult condition. This consists of excision of all of the major ducts. Hadfield's operation. It is particularly important to shave the back of the nipple to ensure that all terminal ducts are removed. Failure to do so will lead to recurrence. Aberrations of normal development and involution nomenclature. The nomenclature of benign breast disease is confusing. This is because over the last century a variety of clinicians and pathologists have chosen to describe a mixture of physiological changes and disease processes according to a variety of clinical, pathological and etiological terminology, as well as leading to confusion. Patients were often unduly alarmed or overtreated by ascribing a pathological name to a variant of physiological development. To address this confusion, a concept, aberrations of normal development and involution, ANDI, has been developed and described by the Cardiff Breast Clinic. Etiology: the breast is a dynamic structure that undergoes changes throughout a woman's reproductive life and, superimposed upon this, cyclical changes throughout the menstrual cycle. This is illustrated in Figure 53.18. The pathogenesis of ANDI involves disturbances in the breast physiology extending from a perturbation of normality to well-defined disease processes. There is often little correlation between the histological appearance of the breast tissue and the symptoms. Pathology: the disease consists essentially of four features that may vary in extent and degree in any one: breast cyst formation. Cysts are almost inevitable and very variable in size. Fibrosis: fat and elastic tissues disappear and are replaced with dense white fibrous trabeculae. The interstitial tissue is infiltrated with chronic inflammatory cells. Hyperplasia of epithelium in the lining of the ducts and acini may occur, with or without atypia papillomatosis. The epithelial hyperplasia may be so extensive that it results in papillomatous overgrowth within the ducts. Clinical features: the symptoms of ANDI are many, as the term is used to encompass a wide range of benign conditions, but often include an area of lumpiness, seldom discrete and/or breast pain, mastalgia. A benign discrete lump in the breast is commonly a cyst or a fibroadenoma. True lipomas occur rarely. Lumpiness may be bilateral, commonly in the upper outer quadrant or, less commonly, confined to one quadrant of one breast. The changes may be cyclical, with an increase in both lumpiness and often tenderness before a menstrual period. Non-cyclical mastalgia is more common in perimenopausal than postmenopausal women. It may be associated with ANDI or with periductal mastitis. It should be distinguished from referred pain, for example a musculoskeletal disorder, breast pain in postmenopausal women not taking hormone replacement therapy. HRT is usually derived from the chest wall, back or neck. About 5% of breast cancers exhibit pain at presentation, but rarely as the sole presenting feature. Treatment of lumpy breasts: if the clinician is confident that he or she is not dealing with a discrete abnormality, and clinical confidence is supported by mammography and/or ultrasound scanning if considered appropriate, the woman can initially be offered firm reassurance. It is perhaps worthwhile reviewing the patient at a different point in the menstrual cycle. For example, 6 weeks after the initial visit, as often the clinical signs will have resolved by that time. There is a tendency for women with lumpy breasts to be rendered unnecessarily anxious and to be submitted to multiple random biopsies because the clinician lacks the courage of his or her convictions. Rapid referral into the secondary healthcare system often means patients are assessed without an intervening menstrual cycle, and this may lead to additional concerns. Treatment of mastalgia: pronounced cyclical mastalgia may become a significant clinical problem if the pain and tenderness interfere with the woman's life, disturb her sleep, and impair sexual activity. Initially, firm reassurance that the symptoms are not associated with cancer will help the majority of women. Acknowledgement that this is a real symptom, a non-dismissive attitude, and an explanation of the etiology are all helpful in managing this condition. In the first instance, an appropriately fitting and supportive bra should be worn throughout the day, and a soft bra, such as a sports bra, worn at night. Avoiding caffeine drinks is said to help. A patient's symptom diary will help her to chart the pattern of pain throughout the month and thus determine whether this is cyclical mastalgia. This allows the majority of patients to adjust to the concept of a cyclical nature of their problem, but if reassurance is inadequate, then a planned escalation of treatment, Table 53.1, could be advised. Oil of evening primrose, inadequate doses given over 3 months, will help more than half of these women. It appears to achieve higher response rates in those over 40 years of age rather than younger women. For those with intractable symptoms, an antagonidotrophin, such as danazol, or a prolactin inhibitor, such as bromocriptine, may be tried. Very rarely it is necessary to prescribe an antiestrogen, for example tamoxifen, or a luteinizing hormone-releasing hormone, LHRH agonist, to deprive the breast epithelium of oestrogenic drive. For non-cyclical mastalgia, it is important to exclude extramammary causes such as chest wall pain, Tietze syndrome. This is common in postmenopausal women who are not taking HRT, and the neck and shoulders are common sites of referred pain. It is seldom necessary these days to carry out a biopsy on a very localized tender area that might be harboring a subclinical cancer, as imaging is so much better. Treatment may be with non-steroidal analgesics or by injection with local anesthetic on a trigger spot. Breast cysts: these occur most commonly in the last decade of reproductive life as a result of a non-integrated involution of stroma and epithelium. They are often multiple, may be bilateral, and can mimic malignancy. Diagnosis can be confirmed by aspiration and/or ultrasound. They typically present suddenly and cause great alarm. Prompt diagnosis and drainage provides immediate relief. Treatment: a solitary cyst or small collection of cysts can be aspirated. If they resolve completely, and if the fluid is not blood-stained, no further treatment is required. However, 30% will recur and require reaspiration. Cytological examination of cyst fluid is no longer practiced routinely. If there is a residual lump or if the fluid is blood-stained, a core biopsy or local excision for histological diagnosis is advisable, which is also the case if the cyst reforms repeatedly. This will exclude cystadenocarcinoma, which is more common in elderly women. Galactosile is rare and usually presents as a solitary, subareolar cyst and always dates from lactation. It contains milk, and in long-standing cases its walls tend to calcify. Fibroadenoma: these usually arise in the fully developed breast between the ages of 15 and 25 years. Although occasionally they occur in much older women, they arise from hyperplasia of a single lobule and usually grow up to 2-3 centimeters in size. They are surrounded by a well-marked capsule and can thus be enucleated through a cosmetically appropriate incision. A fibroadenoma does not require excision unless associated with suspicious cytology. It becomes very large or the patient expressly desires the lump to be removed. Alternatives to surgery include cryoablation, heating with high-frequency ultrasound, Echotherapy removal with a large core vacuum biopsy system. Even if clinically obvious, a biopsy should be obtained if the patient is over 25 or there are any atypical features on ultrasound. Giant fibroadenomas occasionally occur during puberty. They are over 5 centimeters in diameter and are often rapidly growing but, in other respects, are similar to smaller fibroadenomas and can be enucleated through a submammary incision. They are more common in the Afro-Caribbean population. Phyllodes tumor. These benign tumors, previously sometimes known as serocystic disease of Brody or cystosarcoma phyllodes, usually occur in women over the age of 40 years but can appear in younger women. They present as a large, sometimes massive, tumor with an unevenly bossylated surface. Figure 53.19. Occasionally, ulceration of overlying skin occurs because of pressure necrosis. Despite their size, phyllodes tumors remain mobile on the chest wall. Histologically, there is a wide variation in their appearance, with some with low malignant potential resembling a fibroadenoma and others having a higher mitotic index, which are histologically worrying. The latter may recur locally but, despite the name of cystosarcoma phyllodes, they are rarely cystic and only very rarely develop features of a sarcomatous tumor. These may metastasize via the bloodstream. Treatment for the benign type is enucleation in young women or wide local excision. Massive tumors, recurrent tumors and those of the malignant type will require mastectomy. When the diagnosis of carcinoma is in doubt, there will always be situations in which the clinician cannot be sure whether a particular lump in the breast is an area of mammary dysplasia, a benign tumor or an early carcinoma. If there is doubt on clinical, cytological radiological examination, it is essential to obtain a tissue diagnosis. This is often possible by needle biopsy. In the event of a negative result, open biopsy of the mass or large gauge vacuum biopsy is necessary. Because of the possibility of reporting errors and because the histology is likely to be more difficult, if a diagnosis has not already been made, the author suggests that frozen section reporting should be used rarely and certainly should not form the basis for a decision to undertake a mastectomy. Table 53.2 gives an algorithm for investigating any breast lump. Risk of malignancy developing in association with benign breast pathology. The relative risks of malignancy developing according to different histological features found at biopsy are illustrated in Table 53.3. These were elucidated 30 years ago but remain pertinent, and a recent single-center review reinforces the conclusion that the histological classification of the benign lesion in combination with a family history of breast cancer are important predictors of risk. Carcinoma of the breast. Breast cancer is the most common cause of death in middle-aged women in Western countries. In England and Wales, 1 in 12 women will develop the disease during their lifetime. The incidence is expected to continue rising as the population ages, although more slowly than previously thought as the use of HRT has reduced in the USA and UK. Etiological factors. Geographical carcinoma of the breast occurs commonly in the Western world, accounting for 3 to 5% of all deaths in women. In resource-poor countries it accounts for 1 to 3% of deaths. Age. Carcinoma of the breast is extremely rare before the age of 20 years but, thereafter, the incidence steadily rises so that by the age of 90 years nearly 20% of women are affected. Gender. Less than 0.5% of patients with breast cancer are male. Genetic breast cancer occurs more commonly in women with a family history of breast cancer than in the general population. Breast cancer related to a specific mutation accounts for about 5% of breast cancers, yet has far-reaching repercussions in terms of counseling and tumor prevention in these women. This will be discussed more fully in a subsequent section. Diet. Because breast cancer so commonly affects women in the developed world, dietary factors may play a part in its causation. There is some evidence that there is a link with diets low in phytoestrogens. Alcohol consumption is associated with an increased risk. Endocrine breast cancer is more common in nulliparous women, and breastfeeding in particular appears to be protective. Also protective is having a first child at an early age, especially if associated with late menarche and early menopause. It is known that in postmenopausal women, breast cancer is more common in the obese. This is thought to be because of an increased conversion of steroid hormones to estradiol in the body fat. Recent studies have clarified the role of exogenous hormones, in particular the oral contraceptive pill and HRT, in the development of breast cancer. For most women, the benefits of these treatments will far outweigh the small putative risk. However, long-term exposure to the combined preparation of HRT does significantly increase the risk of developing breast cancer. The recent fall in use of HRT in USA and UK has seen a reduction in the incidence of breast cancer in the 50-60-year-old cohort. Previous radiation. This was considered to be of historical interest, as the majority of women exposed to the atomic bombs at Hiroshima and Nagasaki have now died. It was, however, also a problem in women who had been treated with mantle radiotherapy as part of the management of Hodgkin's disease, in which significant doses of radiation to the breast were received. The risk appeared about a decade after treatment and was higher if radiotherapy occurred during breast development. A surveillance program was organized in the UK with MRI and mammographic screening. This type of radiotherapy is now no longer used, and the cohort of patients at risk is now small. Pathology. Breast cancer may arise from the epithelium of the duct system anywhere from the nipple end of the major lactiferous ducts to the terminal duct unit, which is in the breast lobule. The disease may be entirely in situ, an increasingly common finding with the advent of breast cancer screening, or may be invasive cancer. The degree of differentiation of the tumor is usually described using 3 grades: well differentiated, moderately differentiated, or poorly differentiated. Commonly, a numerical grading system based on the scoring of 3 individual factors, nuclear pleomorphism, tubule formation, and mitotic rate, is used, with grade 3 cancers roughly equating to the poorly differentiated group. Previously, descriptive terms were used to classify breast cancer: serous, meaning woody, or medullary, meaning brain-like. Recently, histological descriptions have been used. These have been shown to have clinical correlations in the way that the tumor behaves. However, with the increasing application of molecular markers, there is a change in the way that breast cancers are classified, and it is likely that much more information about an individual tumor will be routinely reported, such as its likelihood of metastasis and to which therapeutic agents it will be susceptible. Gene array analysis of breast cancers has identified 5 major subtypes: luminal A and luminal B, triple negative, HER2 receptor positive, and a miscellaneous group. Some of these correlate with known markers such as estrogen receptor status. There are specific gene signatures that correlate with response to chemotherapy or poor prognosis. A commercial test is now available to patients with estrogen-positive tumors to assess their risk of recurrence. This is based on analysis of 21 genes and may allow selection of patients in whom more aggressive therapy is indicated. Current nomenclature: ductal carcinoma is the most common variant, with lobular carcinoma occurring in up to 15% of cases. There are subtypes of lobular cancer, including the classical type, that carry a better prognosis than the pleomorphic type. Occasionally, the picture may be mixed with both ductal and lobular features. There are different patterns of spread depending on histological type. If there is doubt whether a tumor is predominantly lobular in type, immunohistochemical analysis using the Cadherin antibody, which reacts positively in lobular cancer, will help in diagnosis. Rarer histological variants, usually carrying a better prognosis, include colloid or mucinous carcinoma, whose cells produce abundant mucin; medullary carcinoma, with solid sheets of large cells often associated with a marked lymphocytic reaction; and tubular carcinoma. Invasive lobular carcinoma is commonly multifocal and/or bilateral, hence the increasing use of MRI for assessment. Cases detected via the screening program are often smaller and better differentiated than those presenting to the symptomatic service and are of a special type. Inflammatory carcinoma is a fortunately rare, highly aggressive cancer that presents as a painful, swollen breast, which is warm with cutaneous edema. This is the result of blockage of the subdermal lymphatics with carcinoma cells. Inflammatory cancer usually involves at least 1/3 of the breast and may mimic a breast abscess. A biopsy will confirm the diagnosis and show undifferentiated carcinoma cells. It used to be rapidly fatal, but with aggressive chemotherapy and radiotherapy and with salvage surgery the prognosis has improved considerably. In situ carcinoma is pre-invasive cancer that has not breached the epithelial basement membrane. This was previously a rare, usually asymptomatic, finding in breast biopsy specimens but is becoming increasingly common because of the advent of mammographic screening. It now accounts for over 20% of cancers detected by screening in the UK. In situ carcinoma may be ductal, DCIS, or lobular, LCIS, the latter often being multifocal and bilateral. Both are markers for the later development of invasive cancer, which will develop in at least 20% of patients. Although mastectomy is curative, this constitutes overtreatment in many cases. The best treatment for in situ carcinoma is the subject of a number of ongoing clinical trials. DCIS may be classified using the Van Nuys system, which combines the patient's age, type of DCIS and presence of microcalcification, extent of resection margin and size of disease. Patients with a high score benefit from radiotherapy after excision, whereas those of low grade, whose tumor is completely excised, need no further treatment. Staining for estrogen and progesterone receptors is now routine, as their presence will indicate the use of adjuvant hormonal therapy with tamoxifen or an aromatase inhibitor, AI. Figure 53.20. Tumors are also stained for HER2 or CERB2, a growth factor receptor, as patients who are positive can be treated with the monoclonal antibody trastuzumab, Herceptin registered sign, either in the adjuvant relapse setting. The pathologist is an important member of the breast cancer team and will increasingly help decide which adjuvant therapies will be appropriate. Paget's disease of the nipple. Paget's disease of the nipple, figure 53.21, is a superficial manifestation of an underlying breast carcinoma. It presents as an eczema-like condition of the nipple and areola, which persists despite local treatment. The nipple is eroded slowly and eventually disappears. If left, the underlying carcinoma will sooner or later become clinically evident. Nipple eczema should be biopsied if there is any doubt about its cause. Microscopically, Paget's disease is characterized by the presence of large, ovoid cells with abundant, clear, pale staining cytoplasm in the Malpighian layer of the epidermis. The spread of breast cancer. Local spread. The tumor increases in size and invades other portions of the breast. It tends to involve the skin and to penetrate the pectoral muscles and even the chest wall if diagnosed late. Lymphatic metastasis. Lymphatic metastasis occurs primarily to the axillary and the internal mammary lymph nodes. Tumors in the posterior one-third of the breast are more likely to drain to the internal mammary nodes. The involvement of lymph nodes has both biological and chronological significance. It represents not only an evolutional event in the spread of the carcinoma but is also a marker for the metastatic potential of the tumor. Involvement of supraclavicular nodes and of any contralateral lymph nodes represents advanced disease. Spread by the bloodstream. It is by this route that skeletal metastases occur, although the initial spread may be via the lymphatic system. In order of frequency, the lumbar vertebrae, femur, thoracic vertebrae, rib and skull are affected, and these deposits are generally osteolytic. Metastases may also commonly occur in the liver, lungs and brain and, occasionally, the adrenal glands and ovaries. They have, in fact, been described in most body sites. Analysis of peripheral blood samples for circulating tumor deoxyribonucleic acid DNA has shown prognostic significance and can be used to monitor response. Clinical presentation. Although any portion of the breast, including the axillary tail, may be involved, breast cancer is found most frequently in the upper outer quadrant. Figures 53.22 and 53.23. Most breast cancers will present as a hard lump, which may be associated with indrawing of the nipple or overlying skin. As the disease advances locally, there may be skin involvement with peau d'orange, figure 53.24, or frank ulceration and affixation to the chest wall, figure 53.25. This is described as cancer and cures when the disease progresses around the chest wall. About 5% of breast cancers in the UK will present with either locally advanced disease or symptoms of metastatic disease. This figure is much higher in resource-poor countries. These patients must then undergo a staging evaluation so that the full extent of their disease can be ascertained. This will include a careful clinical examination, chest radiograph, computed tomography, CT of the chest and abdomen, and a bone scan, either using isotopes or MRI. Figure 53.26. This is important for both prognosis and treatment. A patient with widespread visceral metastases may obtain an increased length and quality of survival from systemic hormone therapy or chemotherapy, but is unlikely to benefit from surgery as she will die from her metastases before local disease becomes a problem. In contrast, patients with relatively small tumors, 2 centimeters in diameter confined to the breast with negative ipsilateral lymph nodes, rarely need staging beyond a good clinical examination as the pickup rate for distant metastases is so low. Currently, there are no tests recommended for screening of patients with early-stage breast cancer. Staging of breast cancer. Classical staging of breast cancer by means of the TNM, tumor node metastasis, or UICC, Union Internationale contre le Cancer, criteria is used less often with increased knowledge of the biological variables that affect prognosis. It is becoming clear that these factors, discussed in more detail below, rather than anatomical mapping that influence outcome and treatment. Perhaps a more pragmatic approach would be to classify patients according to the treatment that they require. Table 53.4. Treatment recommendations are summarized in consensus statements such as those from the American Society of Clinical Oncology, ASCO, and the St. Gallen Conference. Prognosis of breast cancer. The best indicators of likely prognosis in breast cancer remain tumor size, grade, and lymph node status. However, it is realized that some large tumors will remain confined to the breast for decades, whereas some very small tumors are incurable at diagnosis. Hence, the prognosis of a cancer depends not on its chronological age but on its invasive and metastatic potential. In an attempt to define which tumors will behave aggressively, and thus require early systemic treatment, a host of prognostic factors have been described. These include the histological grade of the tumor, hormone receptor status, measures of tumor proliferation such as Ki67, growth factor analysis, and oncogene or oncogene product measurements. Many others are under investigation but have proved of little practical value in patient management. Prognostic indices, such as the Nottingham Prognostic Index, have combined these factors to allow subdivision of patients into discrete prognostic groups. Recently, computer-aided programs, Adjuvant Online, www.adjuvantonline.com, or in the UK Predict, www.predict.nhs.uk, have been developed, which incorporate the putative benefits of treatment, allowing oncologist and patient to visualize the benefits of therapy. Treatment of cancer of the breast. The two basic principles of treatment are to reduce the chance of local recurrence and the risk of metastatic spread. Treatment of early breast cancer will usually involve surgery with or without radiotherapy. Systemic therapy such as chemotherapy or hormone therapy is added if there are adverse prognostic factors such as lymph node involvement, indicating a high likelihood of metastatic relapse. At the other end of the spectrum, locally advanced or metastatic disease is usually treated by systemic therapy to palliate symptoms, with surgery playing a much smaller role. An algorithm for the management of breast cancer is shown in summary box 53.3. The multidisciplinary team approaches in all branches of medicine. Good doctor-patient communication plays a vital role in helping to alleviate patient anxiety. Participation of the patient in treatment decisions is of particular importance in breast cancer when there may be uncertainty as to the best therapeutic option and the desire to treat the patient within the protocol of a controlled clinical trial. As part of the preoperative and postoperative management of the patient, it is often useful to employ the skills of a trained breast counselor and also to have available advice on breast prosthesis, psychological support, and physiotherapy, when appropriate. In many specialist centers, the care of breast cancer patients is undertaken as a joint venture between the surgeon, medical oncologist, radiotherapist, and allied health professionals such as the clinical nurse specialist. This has been shown to be good for the patient, to lead to higher trial entry, and to improve the mental health of the professionals in the breast team. There are published guidelines for the optimal management of patients with breast cancer such as SIGN 84, Scottish Intercollegiate Guidelines Network, www.sign.ac.uk/guidelines fulltext/84. Local treatment of early breast cancer. Local control is achieved through surgery and radiotherapy. Surgery still has a central role to play in the management of breast cancer, but there has been a gradual shift towards more conservative techniques, backed up by clinical trials that have shown equal efficacy between mastectomy and local excision followed by radiotherapy. It was initially hoped that avoiding mastectomy would help to alleviate the considerable psychological morbidity associated with breast cancer, but recent studies have shown that over 30% of women develop significant anxiety and depression following both radical and conservative surgery. After mastectomy, women tend to worry about the effect of the operation on their appearance and relationships, whereas after conservative surgery they may remain fearful of a recurrence. Mastectomy is indicated for large tumors, in relation to the size of the breast, central tumors beneath or involving the nipple, multifocal disease, local recurrence, or patient preference. The radical Halsted mastectomy, which included excision of the breast, axillary lymph nodes, and pectoralis major and minor muscles, is no longer indicated as it causes excessive morbidity with no survival benefit. The modified radical pedimastectomy is more commonly performed and is thus described below. Simple mastectomy involves removal of only the breast with no dissection of the axilla, except for the region of the axillary tail of the breast, which usually has attached to it a few nodes low in the anterior group. Pedimastectomy. The breast and associated structures are dissected on block figure 53.27, and the excised mass is composed of the whole breast, a large portion of skin, the center of which overlies the tumor but which always includes the nipple, all of the fat, fascia and lymph nodes of the axilla. The pectoralis minor muscle is either divided retracted to gain access to the upper two-thirds of the axilla. The axillary vein and nerves to the serratus anterior and latissimus dorsi, the thoracodorsal trunk, should be preserved. The intercostal brachial nerves are usually divided in this operation, and the patient should be warned about sensation changes postoperatively. The wound is drained using a wide-bore suction tube. Early mobilization of the arm is encouraged, and physiotherapy helps normal function to return very quickly. Most patients are able to resume light work within a few weeks. Conservative breast cancer surgery. This is aimed at removing the tumor plus a margin of normal breast tissue. This is commonly referred to as a wide local excision. The term lumpectomy should be reserved for an operation in which a benign tumor is excised and in which a large amount of normal breast tissue is not resected. A quadrantectomy involves removing the entire segment of the breast that contains the tumor. Both of these operations are usually combined with axillary surgery, usually via a separate incision in the axilla. There are various options that can be used to deal with the axilla, including sentinel node biopsy, sampling, removal of the nodes behind and lateral to the pectoralis minor, level 2, or a full axillary dissection, level 3. The width of the margin has attracted much controversy, with some units adopting a 1 cm margin and others 1 mm. A recent consensus meeting has suggested that no tumor at the inked margin is sufficient, although the trials upon which this is based have been challenged and many still regard 1 mm as a safer margin. There is no need for wider margins than this. There is a somewhat higher rate of local recurrence following conservative surgery, even if combined with radiotherapy, but the long-term outlook in terms of survival is unaffected. Local recurrence is more common in younger women and in those with high-grade tumors and involved resection margins. Patients whose margins are involved should have a further local excision, or a mastectomy, before going on to radiotherapy. Local excision of a breast cancer without radiotherapy is associated with an unacceptably high local recurrence rate. The role of axillary surgery is to stage the patient and to treat the axilla. The presence of metastatic disease within the axillary lymph nodes remains the best single marker for prognosis. However, treatment of the axilla does not affect long-term survival, suggesting that the axillary nodes act not as a reservoir for disease but as a marker for metastatic potential. It used to be accepted that only premenopausal women should have their axilla staged by operation, as there was a good case for giving chemotherapy to lymph node positive patients. However, it is now clear that postmenopausal women also benefit from chemotherapy, and so all patients require axillary staging. In postmenopausal patients, tamoxifen was once given regardless of axillary lymph node status, but it is now known that only hormone receptor positive patients, irrespective of age, benefit from this. Axillary surgery should not be combined with radiotherapy to the axilla because of excess morbidity. Removal of the internal mammary lymph nodes is unnecessary. Sentinel node biopsy. This technique has become the standard of care in the management of the axilla in patients with clinically node-negative disease. An axillary ultrasound is now routinely performed along with the ultrasound of the breast cancer. Any suspicious nodes can be biopsied by either cytology or core biopsy. The sentinel node is localized perioperatively by the injection of patent blue dye, figure 53.28, and radioisotope labeled albumin in the breast. The recommended site of injection is in the subdermal plexus around the nipple, although some still inject on the axillary side of the cancer. The marker passes to the primary node, draining the area, and is detected visually and with a handheld gamma camera. Perioperative diagnosis allows completion axillary clearance if nodal disease is detected. This may be achieved with frozen section analysis, touch imprint cytology, DIC, or by molecular methods. These involve homogenizing the node and detection of a gene such as cytokeratin 19 or hemoglobin. In some cases, there are only subcapsular micrometastases that are missed at frozen section. In patients in whom there is no tumor involvement of the sentinel node, further axillary dissection can be avoided. The utility of intraoperative diagnosis is increasingly questioned. It is time-consuming, and with increasing use and experience of axillary ultrasound, the rate of unexpectedly positive nodes is low. Moreover, there is increasing adoption of no further surgery even if a positive sentinel node is encountered. A nomogram outlining the chances of further axillary node positivity has been developed by the group at Memorial Sloan Kettering Hospital, New York, and is available on their website, www.mskcc.org/mskcc/html. 15938 CFM. Recent trial results have called into question the utility of completion axillary clearance after a positive sentinel node has been detected, but at present this remains controversial. Radiotherapy to the chest wall after mastectomy is indicated in selected patients in whom the risks of local recurrence are high. This includes patients with large tumors and those with large numbers of positive nodes or extensive lymphovascular invasion. There is some evidence that postoperative chest wall radiotherapy improves survival in women with node-positive breast cancer. It is conventional to combine conservative surgery with radiotherapy to the remaining breast tissue. Recurrence rates are too high for treatment by local excision alone except in special cases, small node-negative tumors of a special type. Trials are underway to investigate whether radiotherapy can be given intraoperatively at one sitting or as an accelerated postoperative course. This would have considerable advantages in making conservative surgery available in areas where radiotherapy is not currently used. It would also relieve the burden of the current demand for radiotherapy, which accounts for up to 40% of activity in some departments. Extrapolation from the Oxford Overviews of Systemic Therapy, carried out every 5 years, suggests that for every 4 local recurrences avoided, 1 additional life will be spared at 15 years. This figure has recently been challenged, but it does highlight the importance of getting the initial treatment right and avoiding local recurrence. Adjuvant systemic therapy. Over the last 25 years there has been a revolution in understanding of the biological nature of carcinoma of the breast. It is now widely accepted that the outcomes of treatment are predetermined by the extent of micrometastatic disease at the time of diagnosis. Variations in the radical extent of local therapy might influence local relapse but probably do not alter long-term mortality from the disease. However, systemic therapy targeted at these putative micrometastases might be expected to delay relapse and prolong survival. As a result of many international clinical trials and recent world overview analyses, it can be stated with statistical confidence that the appropriate use of adjuvant chemotherapy or hormone therapy will improve relapse-free survival by approximately 30%, which ultimately translates into an absolute improvement in survival of the order of 10% at 15 years. Bearing in mind how common breast cancer is in Northern Europe and the USA, these figures are of major public health importance. Who to treat and with what are still questions for which absolute answers have yet to found, but the data from overviews of recent trials show that lymph node positive and many higher risk node negative women should be advised to have adjuvant combined chemotherapy. Women with hormone receptor positive tumors will obtain a worthwhile benefit from at least 5 years of endocrine therapy, either 20 mg daily of tamoxifen if premenopausal or the AIS, anastrozole, letrozole and exemestane, if postmenopausal. It is no longer appropriate to give hormone therapy to women who do not have estrogen or progesterone receptor positive disease. Recent trials have shown that longer durations of endocrine therapy provide a small extra benefit but with increased toxicity. Hormone therapy. Tamoxifen has been the most widely used hormonal treatment in breast cancer. Its efficacy as an adjuvant therapy was first reported in 1983 and it has now been shown to reduce the annual rate of recurrence by 25%, with a 17% reduction in the annual rate of death. Beneficial effects of tamoxifen in reducing the risk of tumors in the contralateral breast have also been observed, as has its role as a preventative agent. IBIS-I and NSABP, P1 trials. Trials studying the optimal duration of treatment suggest that 5 years of treatment is preferable to 2 years. Other hormonal agents that are also beneficial as adjuvant therapy have been developed. These include the LHRH agonists, which induce reversible ovarian suppression and thus have the same beneficial effects as surgical radiation-induced ovarian ablation in premenopausal receptor-positive women, and the oral AIS for postmenopausal women. AIS are now licensed for treatment of all stages of disease and have been shown to be superior to tamoxifen. A large trial comparing anastrozole to tamoxifen in the adjuvant setting has shown beneficial effect for the AI in terms of relapse-free survival, although no benefit for overall survival. There is an additional reduction in contralateral disease, which makes this drug suitable for a study of prevention, and the side effect profile is different from that of tamoxifen. AIS are more expensive than tamoxifen but are coming off patent protection and generic copies may allow more widespread use. There is an increase in bone density loss with patients taking an AI and a bone density scan is advised prior to commencement with treatment of underlying osteopenia or osteoporosis. Chemotherapy using a first-generation regime such as a 6-monthly cycle of cyclophosphamide, methotrexate and 5-fluorouracil, CMF, will achieve a 25% reduction in the risk of relapse over a 10-15-year period. It is important to understand that this 25% reduction refers to the likelihood of an event happening. For example, a woman with a 96% chance of survival at, for example, 5 years only has a 4% chance of death over this time, and the absolute benefit from chemotherapy would be an increase in survival rate of 1% to 97%. This would not be a sufficient gain to offset the side effects of this potentially toxic therapy. However, for a woman with a 60% chance of dying, 40% survival rate, a 25% reduction in risk would increase her likelihood of survival to 55%, and thus treatment would be worthwhile. CMF is no longer considered adequate adjuvant chemotherapy, and modern second and third generation regimes include an anthracycline, doxorubicin or epirubicin, and the newer agents such as the taxanes. Chemotherapy used to be prescribed only to premenopausal women with a poor prognosis, in whom its effects are likely to be the result, in part, of a chemical castration effect, but it is now also offered to postmenopausal women with poor prognosis disease. Chemotherapy may be considered in node-negative patients if other prognostic factors, such as tumor grade, imply a high risk of recurrence. The effect of combining hormone and chemotherapy is additive, although hormone therapy is started after completion of chemotherapy to reduce side effects. High-dose chemotherapy with stem cell rescue for patients with heavy lymph node involvement has now been shown in controlled trials to offer no advantage and has been abandoned. Primary chemotherapy, neoadjuvant, is being used in many centers for large but operable tumors that would traditionally require a mastectomy, and almost certainly post-operative adjuvant chemotherapy. The aim of this treatment is to reduce tumor volume to enable breast-conserving surgery to be performed. This approach is successful in up to 80% of cases, but is not associated with improvements in survival compared with conventionally timed chemotherapy. Patients who achieve a complete pathological response have increased survival rates. Patients with HER2-positive disease will receive Herceptin as part of their management and have high complete response rates. It is important that tumors have a metallic clip placed into them at the onset of therapy, as otherwise there will be uncertainty about which area to resect once chemotherapy has been completed. There is debate about the safety and utility of sentinel node biopsy pre-induction of chemotherapy. However, it can be safely performed after completion of chemotherapy. Neoadjuvant therapy is also used in the triple-negative cohort of patients, PR and HER2-negative, in patients with breast cancer strongly positive for hormone receptors. A similar effect can be seen following 3 months of endocrine treatment. Newer biological agents will be used more frequently as molecular targets are identified. The first of these, trastuzumab, Herceptin-registered sign, is active against tumors containing the growth factor receptor CERB2. Other agents currently available are lapidanab, an oral combined tyrosine kinase inhibitor, TKI. Other TKIs are in development such as pertuzumab. TDM1 is a drug used in HER2-positive disease where a chemotherapy agent, amlodipine, is bound to an anti-HER2 agent to allow targeted delivery of the chemotherapy to HER2-positive cells. The antivascular growth factor bevacizumab initially showed promise but is now no longer routinely used for adjuvant therapy. It is unclear how and when these agents will be used, whether in combination or instead of standard chemotherapy agents. They are very expensive and unaffordable in many countries. Other agents likely to be used in the next few years include CK4/CDK6 inhibitors for metastatic ER-positive cancer. Follow-up of breast cancer. Patients with breast cancer used to be followed for life to detect recurrence and dissemination. This led to large clinics with little value for either patient or doctor. It is current practice to arrange yearly or 2-yearly mammography of the treated and contralateral breast. There is a move to return the patient early to the care of the general practitioner with fast-track access back to the breast clinic if suspicious symptoms appear. There is currently no routine role for repeated measurements of tumor markers or imaging other than mammography. Phenomena resulting from lymphatic obstruction in advanced breast cancer. Podorange is caused by cutaneous lymphatic edema, figure 53.24, where the infiltrated skin is tethered by the sweat ducts. It cannot swell, leading to an appearance like orange skin. Occasionally, the same phenomenon is seen over a chronic abscess. Lymphedema. Lymphedema of the arm is a troublesome complication of breast cancer treatment, fortunately seen less often now that radical axillary dissection and radiotherapy are rarely combined. However, it does still occur occasionally after either mode of treatment alone and appears at any time from months to years after treatment. There is usually no precipitating cause, but recurrent tumor should be excluded because neoplastic infiltration of the axilla can cause arm swelling as a result of both lymphatic and venous blockage. This neoplastic infiltration is often painful because of brachial plexus nerve involvement. An edematous limb is susceptible to bacterial infection following quite minor trauma, and this requires vigorous antibiotic treatment. Antibiotics may need to be given for much longer than is normal, and patients at risk of infection should have antibiotics readily available to enable treatment to be started promptly. Treatment of late edema is difficult, but limb elevation, elastic arm stockings and pneumatic compression devices can be useful. Cancer ankyras. The skin of the chest is infiltrated with carcinoma and has been likened to a coat. It may be associated with a grossly swollen arm. This usually occurs in cases with local recurrence after mastectomy and is occasionally seen to follow the distribution of irradiation to the chest wall. The condition may respond to palliative systemic treatment, but prognosis in terms of survival is poor. Lymphangiosarcoma. Lymphangiosarcoma is a rare complication of lymphedema with an onset many years after the original treatment. It takes the form of multiple subcutaneous nodules in the upper limb and must be distinguished from recurrent carcinoma of the breast. The prognosis is poor, but some cases respond to cytotoxic therapy or irradiation. Interscapulothoracic, forequarter amputation is rarely indicated. Breast reconstruction. Despite an increasing trend towards conservative surgery, up to 40% of women still require, or want, a mastectomy. These women can now be offered immediate or delayed reconstruction of the breast. Few contraindications to breast reconstruction exist. Even those with a limited life expectancy may benefit from the improved quality of life. However, patients do require counseling before this procedure so that their expectations of cosmetic outcome are not unrealistic. The increasing use of oncoplastic techniques such as volume displacement and volume replacement have opened up the options for increasing conservation rates. Specialist training is required, and close cooperation with established plastic surgeons allows optimal selection of patients. The easiest type of reconstruction is using a silicone gel implant under the pectoralis major muscle. The lateral portion of the implant, which was traditionally left in the subcutaneous plane, is now increasingly covered by an acellular dermal matrix, ADM. This gives a superior cosmetic result. Prior tissue expansion using an expandable saline prosthesis FIRST, or a combined device, creates symptosis of the new breast. If the skin at the mastectomy site is poor, e.g. following radiotherapy, or if a larger volume of tissue is required, a musculocutaneous flap can be constructed either from the latissimus dorsi muscle, an LD flap, figure 53.29, or using the transversus abdominis muscle, a tram flap as shown in figure 53.30. The latter gives an excellent cosmetic result in experienced hands, but is a lengthy procedure and requires careful patient selection. It is now usually performed as a free transfer using microvascular anastomosis, although the pedicle tram from the contralateral side is still used. Variations on the tram flap requiring less muscle harvesting, such as the deep flap, based on deep inferior epigastric vessels, are increasingly being used. The timing of reconstruction may be difficult. Impediments to immediate reconstruction include insufficient theater time and a lack of experienced reconstructive surgeons. In addition, if a patient is likely to need postoperative radiotherapy, then a delayed reconstruction using a flap often gives a better result. Radiotherapy onto a prosthesis often leads to a high incidence of capsular contracture and unacceptable results. Nipple reconstruction is a relatively simple procedure that can be performed under a local anesthetic. Many different types of nipple reconstruction are described, but the majority lose height with time. Tattooing of the reconstructed nipple is often required. Alternatively, the patient can be fitted with a prosthetic nipple. To achieve symmetry, the opposite breast may require a cosmetic procedure such as reduction or augmentation mammoplasty, or mastopexy. A breast reconstructive service can be offered by a suitably trained breast surgeon, a plastic surgeon, or, ideally, using a combined oncoplastic approach. The patient needs to be warned that breast reconstruction is seldom, if ever, one operation. External breast prostheses that fit within the bra are the most common method of restoring volume fill and should be available for all women who do not have an immediate reconstruction. Screening for breast cancer. Because the prognosis of breast cancer is closely related to stage at diagnosis, it would seem reasonable to hope that a population screening program that could detect tumors before they come to the patient's notice might reduce mortality from breast cancer. Indeed, A number of studies have shown that breast screening by mammography in women over the age of 50 years will reduce cause-specific mortality by up to 30%. Following the publication in 1987 of the Forest Report, the National Health Service in the UK launched a program of 3 yearly mammographic screening for women between the ages of 50 and 64 years, now increased to 70 years. The introduction of this program has undoubtedly improved the quality of breast cancer services, but a number of questions remain unanswered, including the value of screening women under 50 years and the ideal interval between screenings. The psychological consequences of false alarms or false reassurances still need to be addressed, and self-examination programs that have failed to show any benefit for the population in terms of earlier detection of or decreased mortality from breast cancer remain controversial. The opponents of screening rightly point out that some women will have disease detected and treated that might never harm them in their lifetime. However, this group of women cannot as yet be reliably separated from those in whom prompt diagnosis and treatment will be beneficial. MRI is used to screen those at very high risk or where radiation might be hazardous. Li-Fraumeni syndrome. There is no place for thermography as a screening or diagnostic tool. Familial breast cancer. Recent developments in molecular genetics and the identification of a number of breast cancer predisposition genes, BRCA1, BRCA2 and page 53, have done much to stimulate interest in this area. Yet women whose breast cancer is due to an inherited genetic change actually account for less than 5% of all cases of breast cancer. That is about 1,250 cases per year in the UK and 9,000 cases in the USA. A much larger number of women will have a risk that is elevated above normal because of an as yet unspecified familial inheritance. These women have a risk of developing breast cancer that is 2-10 times above baseline. The risks associated with family history are summarized in Table 53.5. There are computer programs available to assist the clinician in assessing family history risk. The BRCA1 gene has been associated with an increased incidence of breast and ovarian cancer and is located on the long arm of chromosome 17, 17q. The gene frequency in the population is approximately 0.0006. It does, however, occur with greater frequency in certain populations such as Ashkenazi Jews, in whom there is often a common founder mutation. BRCA2 is located on chromosome 13q and there is an association with male breast cancer. Women who are thought to be gene carriers may be offered breast screening and ovarian screening in the case of BRCA1, which is known to impart a 50% lifetime risk of ovarian cancer, usually as part of a research program, or genetic counseling and mutation analysis. Those who prove to be gene positive have a 50 to 80% risk of developing breast cancer, predominantly while premenopausal. Many will opt for prophylactic mastectomy. Although this does not completely eliminate the risk, it does reduce it considerably. This work should be carried out in specialist centers. For the great majority of women with a positive family history, who are unlikely to be carriers of a breast cancer gene, there are no currently proven breast cancer screening maneuvers. Although this is under investigation, tamoxifen given for 5 years appears to reduce the risk of breast cancer by 30 to 50%, as does the AI, anastrozole. Thus, these women are best served by being assessed and followed up, preferably in a properly organized family history clinic. Pregnancy. The effects of pregnancy on breast cancer are increasingly understood, and it is thought that breast cancer presenting during pregnancy or lactation tends to be at a later stage, presumably because the symptoms are masked by the pregnancy. However, in other respects it behaves in a similar way to breast cancer in a non-pregnant young woman and should be treated accordingly. Thus, treatment is similar with some provisos. Radiotherapy should be avoided during pregnancy, making mastectomy a more frequent option than breast conservation surgery. Chemotherapy should be avoided during the first trimester but appears safe subsequently. Most tumors are hormone receptor negative, and so a hormone treatment, which is potentially teratogenic, is not required. Becoming pregnant subsequent to a diagnosis of breast cancer appears not to alter the likely outcome, but women are usually advised to wait at least 2 years, as it is within this time that recurrence most often occurs. The risk of developing breast cancer with oral contraceptive use is only slight, and disappears 10 years after stopping the oral contraceptive pill. Hormone replacement therapy (HRT) increases the risk of developing breast cancer if taken for prolonged periods and in certain high-risk groups. HRT may also prolong symptoms of benign breast disorders such as cysts and mastalgia and make mammographic appearances more difficult to interpret. Patients who develop breast cancer while on HRT appear to have a more favorable prognosis. The consequences in terms of recurrence in women using HRT following breast cancer are unknown. Treatment of advanced breast cancer. Breast cancer may occasionally present as metastatic disease without evidence of a primary tumor, that is, with an occult primary. The diagnosis is made partly by exclusion of another site for the primary tumor and may be confirmed by histology with special immunohistological stains of the metastatic lesions. Management should be aimed at palliation of the symptoms and treatment of the breast cancer, usually by endocrine manipulation with or without radiotherapy. Locally advanced inoperable breast cancer. Locally advanced inoperable breast cancer, including inflammatory breast cancer, is usually treated with systemic therapy, either chemotherapy or hormone therapy. Occasionally, toilet mastectomy radiotherapy is required to control a fungating tumor, but often incision through microscopically permeated tissues results in a worse outcome. Metastatic carcinoma of the breast. Metastatic carcinoma of the breast will also require palliative systemic therapy to alleviate symptoms. Hormone manipulation is often the first-line treatment because of its minimal side effects. It is particularly useful for bony metastases. However, only about 30% of these tumors will be hormone responsive and, unfortunately, in time even these will become resistant to treatment. First-line hormone therapy for postmenopausal women is now anastrozole or one of the other third-generation AIS, tamoxifen. Ovarian suppression by surgery. For premenopausal women, radiotherapy and medical treatment are all in common use. When resistance to these has developed, other hormonal agents can prove useful, with about one-half of the response rate seen in the first-line therapy. The newer agents such as antiprogestins, pure antioestrogens and growth factor TKIs are all candidates for this role. Cytotoxic therapy is used particularly in younger women or those with visceral metastases and rapidly growing tumors. A variety of regimes is available and, although none prolong survival, contrary to expectations, quality of life and symptom control is often better with more aggressive treatments, with responses being seen in up to 70% of patients. Local treatment may also prove useful for some metastatic disease, such as radiotherapy for painful bony deposits and internal fixation of pathological fractures. The male breast gynecomastia. Idiopathic hypertrophy of the male breast may be unilateral or bilateral. The breasts enlarge at puberty and sometimes present the characteristics of female breasts. Hormonal enlargement of the breasts often accompanied stilbestrol therapy for prostate cancer, now rarely used. It may also occur as a result of a teratoma of the testis, in anorchism and after castration. Rarely, it may be a feature of ectopic hormonal production in bronchial carcinoma and in adrenal and pituitary disease. Bodybuilders may use steroids to improve their physique, which may cause gynecomastia. Some even go so far as to take tamoxifen to mask this symptom. Associated with leprosy. Gynecomastia is very common in men suffering from leprosy. This is possibly because of bilateral testicular atrophy, which is a frequent accompaniment of leprosy. Associated with liver failure. Gynecomastia sometimes occurs in patients with cirrhosis as a result of failure of the liver to metabolize estrogens. It is associated with drugs that interfere with the hepatic metabolism of estrogens. It is also seen with certain drugs such as cimetidine, digitalis and spironolactone. Associated with Klinefelter's syndrome. Gynecomastia may occur in patients with Klinefelter's syndrome, a sex chromosome anomaly having 47 XY trisomy. Treatment provided that the patient is healthy and comparatively young, reassurance may be sufficient. If not, mastectomy with preservation of the areola and nipple can be performed. The patient must be warned about the side effects of this procedure, which are common and a cause of many medico-legal complaints in the UK. Carcinoma of the male breast. Carcinoma of the male breast, figure 53.31, accounts for less than 0.5% of all cases of breast cancer. The known predisposing causes include gynecomastia and excess endogenous or exogenous estrogen. As in the female, it tends to present as a lump and is most commonly an infiltrating ductal carcinoma. Treatment stage. For stage, the treatment is the same as for carcinoma in the female breast and prognosis depends upon stage at presentation. Adequate local excision, because of the small size of the breast, should always be with a mastectomy. Other tumors of the breast. Lipoma. A true lipoma is very rare. Sarcoma of the breast. Sarcoma of the breast is usually of the spindle cell variety and accounts for 0.5% of malignant tumors of the breast. Some of these growths arise in an intracanalicular fibroadenoma or may follow previous radiotherapy, e.g. for Hodgkin's lymphoma. Many years previously, it may be impossible to distinguish clinically a sarcoma of the breast from a medullary carcinoma, but areas of cystic degeneration suggest a sarcoma, and on incising the neoplasm it is pale and friable. Sarcoma tends to occur in younger women between the ages of 30 and 40 years. Treatment is by simple mastectomy followed by radiotherapy. The prognosis depends on the stage and histological type. Metastases. On rare occasions, cancer elsewhere may present with a metastasis in the breast. The breast is also occasionally infiltrated by Hodgkin's disease and other lymphomas.